We're talking with board-certified plastic and reconstructive surgeon Dr. Jeffrey Scott. We're on location from the Plastic Surgery Center with offices both in the Sarasota and Bradenton area. Dr. Scott, again, we thank you for joining us today.
Thank you.
We've been talking about breast surgeries. Primarily, we've focused on the reconstructive stages of the breast surgery. But there is much more involved in that, as you gave us just a very quick list when we began. You had mentioned the implants, so perhaps we can go to that area right now. And I think even still to this day, there's a lot of people that have questions about the implants, particularly after the events of a few years ago. So maybe we should address that first.
Well, the vast majority of implants that we're using today are saline implants. What is a saline implant? Saline implant is a deflated silicone rubber shell that we actually inflate with saline. Saline is salt water. It's a physiologic solution, the same solution that you get in your veins whenever you're receiving intravenous fluid. So we certainly know that the saline itself is very safe. The silicone rubber shell is not silicone gel, which is what kind of caused the uproar of years ago. That's a whole different topic in and of itself. But the vast majority of implants used today are saline. One of the downside to any breast implant surgery, for breast enlargement, is what's called a capsular contracture, or the scar tissue capsule that forms around the implant. If it becomes a little firm and squeezes on the implant, can cause some unnatural firmness. And the incidence of that is less with saline implants than it is with silicone gel implants. So from that standpoint, especially, it's been very good. The incidence of capsular contracture or hardening with silicone gel implants was upwards of 20 to 25%, and it's less than 5% with saline implants. The implants can be placed either underneath the muscle or on top of the muscle, and that's the pectoralis muscle. It really depends on the woman, the size of their native breast tissue that they have, the amount of droopiness they have. So there's a number of factors that go into the decision as to whether to place them above or beneath the muscle. My personal preference is to place them beneath the muscle if they don't have too much droopiness. So that's the first decision to make, between underneath the muscle or on top of the muscle. And the next decision is where to make the incision. I'd say the vast majority of the time, a small incision of about a little over an inch, approaching an inch and a half in length, is placed underneath the breast at the inframammary fold. That's a real good option. It's a direct approach to dissecting the pocket out and doing the surgery. Another option is to place the incision around the areola, or the pigmented portion of the breast. I personally don't like that option. I think that it places the incision on the front of the breast, making it visible. The third option is to make the incision underneath the armpit. That's probably the most involved option, in that if we're going to do that, we need to do it, the surgery we need to do endoscopically. I think everybody's heard of arthroscopic surgery on the knee and that sort of thing, where small incisions are made but the surgery is done with the scope. That's the same sort of thing if we're going to make the incision underneath the armpit. The breast is kind of a remote location from there, so we have to dissect it and everything with the endoscope. That's fine. It just adds a little length to the procedure. That approach is for the woman that definitely does not want any incision anywhere on the breast. It just adds a little additional time and a little additional cost to the patient. But those are the three primary incision options.
When the woman is making a decision on exactly what type of procedure that she wants, size becomes a factor. Is that something, are there limitations?
The limitations are basically the woman's, the amount of laxity that they have, if they've had children, or, if you've never had any kids and you've got very small breasts and not much excess, only so much will fit in that pocket. Whereas someone with maybe that's lactated and has some more laxity to the skin could accommodate a larger implant. And the other issue is the chest wall, the circumference of the rib cage. There's very tall women with very narrow chest walls, and conversely short women with wide chest walls. We all come with different body habituses. But basically, as the implant gets larger, the base diameter of the implant gets larger too. So it kind of goes without saying, a small chest, rib cage chest, can only accommodate a certain sized implant without, coming too far out to the side or being too full up top. So usually everyone's chest, not their breast, but their chest dictates ultimately what size implant they can accommodate.